I will present my thoughts on how to optimize drainage in the retinal detachment surgery in order to avoid retinal folds and displacement. Displacement and folds indicate that the detached retina does not settle down in the original location. It might occur with any type of surgery, either episcleral or endobulbar. When operating a primary retinal detachment with episcleral surgery, the key steps that lead to displacement and folds are the amount of indentation, the postoperative position when gas or air are injected, and the intraoperative drainage. Drainage has a role because the more the subretinal fluid at the end of surgery, the more likely it is to have displacement and folds. When operating primary retinal detachment with vitrectomy, the key steps that lead to displacement and folds are the modality of the final exchange, the postoperative position, and the modality of drainage. So drainage of subretinal fluid is certainly a key step in determining the results of retinal detachment surgery, not just anatomical but mostly functional. Let's see in how many ways we can drain. This is a very common example. An eye with retinal detachment due to a supratemporal break. In the video on top, I am aspirating the fluid through the break with the vitrectomy probe during air injection. In the video on the bottom, I am aspirating the subretinal fluid through the break with the vitrectomy probe, while injecting first PFCL to flatten the retina. In the top video, I am completing the fluid air exchange by aspirating the residual fluid at the posterior pole, and the retinal break is flattened by air. In the video on the bottom, I am completing the fluid PFCL air exchange by aspirating the residual PFCL at the posterior pole. The retinal break is flattened by air. We might think that with the technique with the PFCL, we have no subretinal fluid at the end of the exchange. But, as demonstrated also by the intraoperative OCT, there will always be residual subretinal fluid, no matter if we use or if we do not use PFCL. If you can see here, the intraoperative OCT shows that while the posterior retina is flat under PFCL, it is not flat at the end of the fluid air exchange. Let's see an example of retinal fold. Any type of detachment is at risk of displacement and fold, but the significant lesions are the ones that affect vision at the posterior pole. Hence, the detachments at higher risk are the superior detachments involving half of the macula. This is in fact an example of retinal detachment with half macula detached, as confirmed by the OCT. I am treating this detachment with a complete vitrectomy and with the drainage of subretinal fluid through the break and with fluid air exchange. So let's see what happened. 1 week postoperatively, a fold appeared evident in the macula. How to treat the retinal fold? Well, just the massage of the fold is not efficient, and it is actually dangerous for the risk of inducing iatrogenic lesion. So it is necessary to redetach the retina in a wide area. And only when the retina is detached, it can be massaged to open the fold, and a partial fluid air exchange can be done at the end of surgery. But what happened in this case? A macular hole occurred, likely when detaching the macula and injecting subretinal fluid with a 41 gauge needle. The ILM had already been removed. This is an old case, and the ILM flap was not a common practice, so I am aspirating the fluid through the hole and finishing with a new fluid air exchange. So in summary, this case started as a retinal detachment and became a macular fold case, and then a macular hole, and then the end of agony. But this was an extreme example to say that although macular folds are rare, their management is difficult and full of surprises. It is much better to prevent them. So in order to prevent the folds, we should first understand how folds are created. If we select not to use PFCL but only air, we will aspirate the fluid through the break while the air enters the eye. And then, when completing the fluid air exchange, some residual fluid will remain in the macular area. And if the patient is positioned face down, the fold will be impressed against the choroid by the action of the bubble of air. If we select to use PFCL, a very common way is to inject PFCL first up to the break and then to inject air and exchange PFCL with air. Again, if the patient is then positioned face down, the fold will be impressed against the choroid by the action of the bubble of air. A better way to reattach the retina with PFCL is to inject air first up to the break and then inject PFCL up to the break and complete the fluid air exchange. This will minimize the amount of subretinal fluid at the end of the maneuvers. So my advice to avoid the folds is that whether you use or if you do not use PFCL, after the air exchange, leave some fluid on top of the macula, position the patient face up for a few hours, and allow the fovea to settle down, as you see in the sketch on the right. Then position according to the break. It had been proposed to open a posterior retinotomy as an alternative to reabsorb the residual submacular fluid, but I do not recommend this option since it is not necessary. It creates one more retinal hold with the need of laser and possible consequences. So if you just allow it to settle down, it will be reabsorbed by the RPE and with no need of extra breaks. One warning on the use of PFCL: there is always risk to end up with PFCL under the retina. As you can see in the video, the inadvertent subretinal injection of PFCL might happen if we are not careful. And it's very important to realize what happened, and if we do, we have to solve the problem immediately. Like here, I am redirecting the PFCL bubble with the scleral depressor, and I am aspirating the PFCL bubble through the original break. But it is not always possible, and we might end up with a bubble of PFCL like this in the posterior pole and in the fovea. So how to solve the problem? We have different options. If it is not subfoveal, we can directly aspirate the PFCL bubble with the Charles needle. But if it is in the fovea, like in this case, kindly provided by Dr. Muni, we have to detach the retina and try to aspirate the PFCL, in this case with a 41 gauge needle. So in the end, my final advice to avoid the folds are to reabsorb as much subretinal fluid as possible, leave some fluid on top of the macula, position the patient face up for a few hours, and then position according to the break. Thank you.